Okay. Hi, everyone. This is Danielle Varda, and I'm so glad that you are here today. Apologies for being a few minutes late here, but we are going to get started. We have a great webinar today and some amazing guests, friends of VNL who have trusted us with some of their work around our PARTNERme tool. So I'm just going to dive right into this. Today we have a great webinar on measuring social connectedness, and what we've done is invited some of the folks who have engaged with us over the last few months or a year on using PARTNERme, one of our tools at VNL. So the way that our webinar will work today is kind of a two-part webinar. So for this first hour, we're going to start with a quick overview of PARTNERme, just to do some context setting so we know what we're talking about and what the tool is. And then we're going to have a presentation by three of our partners that is a real mix of a discussion, kind of a back and forth of hearing about them and hearing about the tool. So you'll get a real sense of the breadth and variety of different ways that folks are using it and actually doing this kind of work on measuring social connectedness inside their communities. For anyone who's interested, we'll stay on just to do a quick demo and answer questions just about PARTNERme and ways to use it or think about it in your own context at the end of the webinar at 1:30. All right, so I'm going to go into more about each of us, but just a really high level intro of who's here today. We have Dr. Brianne DeBeer, who is from the VA Patient Safety Center of Injury Suicide Prevention Collaborative, and Nicholas Bushholt, who is the Family Services Manager at Jefferson Center, and Caitlin Barba, who is the actually former executive director, right, of the Colorado Center for Primary Care Innovation, the Caitlin, I just forgot your title, at the Westminster Medical Clinic, it's not on here. We're going to go through this in just a second. So everybody's bios, but what we're going to do, the way we're going to focus this is that after we kind of introduce each program and each person and you get to know them a little better, we're going to break up the webinar into three areas. So getting started, like how would you customize PARTNERme or your square to actually be able to measure social connectedness and customize it for different topic areas. And then we're going to talk a little bit about implementation and what it looks like when you're actually screening patients or clients and putting it into the workflow. And then the last section on taking action. So what happens when you have data, both connecting people to resources, but also population analytics that help us really understand the impact of different levels of social connectedness among the different populations that we're serving. So I'll just do a little background before we get started on Visible Network Labs and the actual tool that we're talking about. Our mission, one of the things that we say we do is we help to make invisible networks visible. We all know, many of us, the impact of social connectedness on health and mental health outcomes. And while that isn't as new for most people, what is new is a way to measure that. So making this really critical piece of our outcomes visible and measurable and tangible for our providers means that we might have the opportunity to address it earlier in a person's life and be more preventative about how we can address it throughout their life and their outcomes. So that's what we're working on. We are a social enterprise and we focus on using network science to help strengthen connections and improve outcomes through lots of trainings and workshops, but we really focus on the technology-based data and mapping tools inside of our partner platform that provide tools for people inside communities. PARTNER is our primary platform. It's a data mapping, network mapping system, but it not only maps networks, but we measure networks. And so Unlike systems that just show you the maps, we spend a lot of time trying to understand the outcomes, attribution of those relationships to outcomes, and other kinds of qualities that help us learn in a way that we can translate that back into practice and policies. We're actually all over the country with our partner tool in the world now. We have several projects in about 8 different countries, and lots of our partners are wonderful at actually helping us learn and then fund this work. And so that's how we mostly do a lot of this. So I'm going to just talk about PARTNERme for just a couple minutes so we can get right into our partner profiles. So PARTNERme is a tool on the partner platform. We do refer to it as a person-centered network tool. It's something that's used by a provider. Sometimes we refer to them as helping professionals, but people whose job and role it is to help others. So this could be a clinician, but it also could be a firefighter, a teacher, a counselor, a social worker. And so what we've done is tried to create a tool that can be used in the field or at home or in clinical settings, so that people can have a way to do things like screen a person on their social connectedness in an interactive way that is new and adds new data points and insights to the work that they're doing. Something I failed to say, and I always love to see, is that if you are doing work like this or you have specific questions, you can start putting those in the chat or just introduce yourself. We always just love to make connections while we're on these network leadership webinars. So feel free to put some things in there and we'll keep an eye on it. I'll do a quick overview of PARTNERme because we'll be able to dig into that a little bit more if anyone wants to stay on afterwards. But basically, it's a screener tool. Our focus is on really great measures of really hard concepts. And so this is just an example from a slide deck of what PARTNERme does, but you can add your own questions to it. You can use our default questions. So this is just a really high level example of a couple of questions someone might ask someone about rating your own health or how often you might feel lonely or isolated, which are really great questions to ask, especially like of young people. They don't get asked this question a lot. But what makes PARTNERme unique is that we'll ask something at one point that says, like, who do you rely on when you have problems? Or who helps you with things you need? And as people list names of both friends and family, but also formal connections and supports, it draws a little map like this for them. And then with their finger or their mouse, we'll ask them a question like, who could coordinate care if you needed help? So very quickly, we can get a sense of whether someone perceives that they are embedded in a network of care or not. It's the kind of thing that we know is really critical to an outcome, but we have like no visibility on it. So that's the first thing. Then we'll often ask folks a question about their social needs. So you'll see here kind of a high level list. If you're using this in a pediatric clinic, this will look a little different. For veterans, different. But this list might ask people some basic questions. And normally you would take these 4 needs that someone indicated and then connect them to 4 resources. What we do, which is a little different, is we take those and we draw a new picture for folks and we say, who helps you with the things you need? Because we learned through a bunch of research that people really want to help themselves. They want to be resilient. They want to be able to be acknowledged for the assets they bring to their own care. And this allows us to say, great, you're doing a good job getting childcare and food for your family, but work is something that you seem to have no help with. So let's focus there. And our assumption is that when we refer people to a resource in this way, their follow through will be more successful, and they build trust with their provider because the trust is using a strengths-based approach that says, I believe you want to help yourself, and there are systems resources that can help you. We take all that information and we turn it into reports for folks. I'm not going to go into this very much because we'll get to see more of that in the presentations, including ways to score a person's social connectedness around things like trust and dependency, maybe loneliness and social connectedness. And then the tool does connect folks to resources, which is a way that you can customize and really personalize that finding about their most pressing need with the least amount of social support or other things that you want to sort on inside the tool. And then you we take all that information and drop it into a big systems map so that we can really kind of see from a population level where people are embedded in a resource network and what needs they have. And then the statistics that come along with that around being able to delineate that across populations is, of course, important to learning about return on investment and then investments in new interventions. So the goal with all of our pilots and work that we're working on with the folks that you'll meet today is to really get to this point where they have this information and are able to test it out in their own context. So I'm going to move right over to our guests today to talk a little bit more about them. What I'm going to do is ask each person to come on and do an intro yourself. And so Caitlin, if you're up first. So this is our opportunity to hear from folks right away and learn a little bit more about what they're doing, what their missions are, who they're serving. So we'll do one by one. And Caitlin, I'll go ahead and move your slides if you let me know when.
Sure. So thanks so much, Danielle. Sorry, I'm drinking tea here because I'm home with a little bit of my own cold. So we also have Dr. Scott Hammond, I think, on the call. He's the president of Colorado Center for Primary Care Innovation. I am the former executive director and current program manager. I'm also the practice administrator over at Westminster Medical Clinic. And I'm also a mom of two lovely girls, 6 and 8 years old, and a wife. So the Colorado Center for Primary Care Innovation began about a decade ago. Their current working tagline is making healthcare a caring, personal, and healing experience for all through practice-based research. And that's really the crux of who we are. Next slide. These are the current pillars of the strategic direction for this local nonprofit here in Colorado. It's a 501c3. The top there, addressing health issues that matter, is really kind of where we steer all of our next projects. Number 3 there, that's the practice-based research network called ART2, and I'll go into more about who they are. Next slide. So here's a picture of ART2. ART2 is Aspen Renaissance Transformation Team. Up there in the right-hand corner, back in the early 1980s, there was one of the first practice-based research networks, and it was called Ambulatory Sentinel Practice Network. And we have a picture of aspens there here in Colorado because there's many of them, but also underneath the soil, there's this thought that all aspens are one. And so that's really important in terms of connections. Larry Green there, the first author of this particular paper, he's on the steering committee for this local nonprofit. And so Aspen Renaissance Transformation Team being our modern name of the Ambulatory Sentinel Practice Network. Down here in the lower left corner, we have our fearless president, Dr. Scott Hammond, at our first in-person conference back in 2019, where we were talking about what projects are really going to matter most, back to that number 1 pillar that we showed you on the previous slide. Next slide. So here's a geographic distribution of all of the practices we're looking to grow. We're looking for really innovative and passionate groups to join the local nonprofit. The local nonprofit doesn't do anything in terms of driving our practices, and that's really why we all want to participate together, because we're in charge of what is going to matter most, and then the nonprofit is there to support us with funding, quality improvement, practice innovation. Next slide. So currently we are 8 of the most advanced practices. We're independently owned. We all have integrated behavioral mental health, and we've been doing a number of projects statewide, federally over the years. Really, our philosophy of care comes from the core values of medicine, which can be found online. You can Google them from Beauchamp. Dr. Scott Hammond added that last one after a long dialogue with providers around what is going to bring everyone a sense of fulfillment in their practices. So harmony and practicing care that's really about our own health and well-being, and how we can relate to that in relationships is really what's steering these projects. Maybe ironically, these independently owned practices also have this interest and desire to collaborate. And so it's all threaded together of an aspen and aspen trees. We're all looking to share best practices and grow together as one ourselves. Next slide. So how do we do what we do? Right now, we identify problems, we research them. Sometimes it requires us to invent new things. We've surveyed our clinicians. Generally speaking, they would not call themselves innovators in terms of an innovation curve, but they certainly love to get creative, be curious, and invent. And then we look to figure out how are we going to make whatever is created useful and possible in our practices that solves the problems we identify. So these are some of the questions that we ask ourselves regularly. The last one I'm going to draw out in particular because we do focus on our own health and well-being. We've heard in publications and different areas, heal thyself to heal others, or physician heal thyself to heal others. And so in our practices, we do focus on what are the activities that are going to lend us be able to care for these patients, also ourselves. Next slide.
Okay. So we're going to thank you, Caitlin, and we'll hear a little bit more about the other parts of her project in just a minute. But next, I'm happy to introduce Nicholas Bushholt, Family Services Manager at the Jefferson Center. So Nick, are you there? I'm going to click over to your slide and you can introduce your work and what you all are up to.
Sure. So my name is Nick Buchholz. I am a licensed professional counselor and a licensed addictions counselor in Colorado. I work with the Jefferson Center, and the Jefferson Center is a large community mental health organization. It's not for profit, and we serve 3 of the large counties here in Colorado. Typically, we have about 500 or so employees when we're fully staffed. And in terms of services, if you think behavioral or mental health service, we probably have it. So we do everything from peer services to groups. We do substance abuse, mental health, all across the board. We handle it all. So we are participating with the Colorado Crisis Networks to really facilitate this idea that there's no wrong door for clients to enter mental health services. So we do intakes for anyone that comes in, and we can figure out the appropriate services and get them to where they need to go. We have a really strong connection with a lot of our state agencies, primarily those human services. We do a lot with the youth prevention and kind of intake stuff over there. Do a lot of trainings with them. The Department of Human Services was actually one of the agencies that wanted the trauma systems therapy services, which I'll talk about in a second, and provided some funding for us to be able to do that, which was really awesome. So we work with the courts, we work with local police departments in a co-responding kind of manner. We'll go out with officers to make contact with those in mental health need or distress and provide referrals and things like that. For a long time, we were involved with the juvenile justice jail. We're still involved with the criminal justice system quite a bit through our substance use programs, as well as an in-home therapy program that's called Crossroads. So I guess you can advance the slide. So the trauma systems therapy is one of the teams that I oversee, and this team is the one that's particularly involved with the PARTNERme tool. So in addition to that, I oversee the first episode of psychosis program called Ascent, as well as our adolescent DBT program, but those are not using this tool at this point. So the trauma systems therapy team is what was encouraged by the Department of Human Services, and it's really to provide in-home service for youth, ages 4 to 21. So we cover a huge range. And it really was derived from this need for trauma-informed care. We've seen a huge spike in the need around trauma, and a lot of the current methodologies for working with that weren't kind of up to snuff. So this trauma systems therapy is a treatment model that is designed to first go into the homes and establish a safe environment. And then we teach regulation skills, and then we go all the way through processing of trauma. So it's kind of a beginning to end trauma treatment. And we work a lot with high needs families that are, a lot of single parents, a lot of grandparents raising their children, a lot of lower SES, some other cultural factors. So one of the draws with the PARTNERme system is really around what is required for clinicians on that team. The clinicians will be not only the therapist, but they are the case manager. They sometimes have to provide triage for the parents or the guardians. They have to provide a full breadth of support. And so we really liked kind of the opportunity to work with VNL on this to help us kind of round out that aspect. What we found is that a lot of our families did not have their basic needs met, and so therapy was stalled as a result of that. So yeah, I think that's pretty much it.
Awesome. Thank you, Nick. We'll hear more when we get back to our topics. So I'm going to switch it over to Brianne. Brianne is from the Rocky Mountain MIRAC at the VA. So Brianne, if you wouldn't mind doing an intro.
Sure. Good afternoon, everyone. It's so nice to be here speaking with you. So I'm Dr. Brianne DeVere. I am the director of the VA Patient Safety Center of Inquiry Suicide Prevention Collaborative. That's a national center within the VA that seeks to develop solutions to suicide prevention for veterans who are in the community. I'm also a clinical research psychologist at the Rocky Mountain MIRAC. So that's Mental Illness Research Education and Clinical Center. So there are probably about 12 MIRACs across the country in various areas. And the one in Denver is focused exclusively on suicide prevention. So the mission is to reduce suicidal ideation and behaviors among veterans by identifying cognitive and neurobiological underpinnings of self-directed violence. So a lot of my work is as a researcher, developing innovations and testing them around mental health and suicide risk in veterans. And the project I'm going to be speaking on today is funded by VA Mental Health Science Research and Development. And have been very grateful to work in collaboration with VNL. And kind of how a lot of this came about was I was introduced to them by a colleague I was working with and started working with them on my patient safety center. And then, some other opportunities arose. And I thought, wow, PARTNERme would really be fantastic for this other project too. There's a lot of flexibility in being able to apply this tool in a lot of different domains. And so for my project, the pandemic occurred, and I thought, for many years, I've wanted to look at a social network analysis in relation to suicide risk in veterans. And I myself don't have that expertise. And so when this came up, I thought, wow, Danielle's team can bring so much insight here into this issue, particularly surrounding COVID-19. We didn't know what was going to happen to our veterans when faced with social distancing and being isolated. And we know that being isolated is a risk factor for suicide. And I've done a lot of that work myself, looking at social support, but being able to look at a social network analysis really takes it to the next level in trying to understand where the challenges are and what is really happening, what's happening beyond perceived social support. That's somewhat of a rudimentary way to assess challenges with social connection. And so we applied for and received funding to examine the impact of social distancing and the COVID-19 pandemic on mental health and suicide risk via a social network analysis using the PARTNERme tool. We had 196 veterans. We oversampled for common mental health symptoms. And we were also fortunate that VA does have quite a research arm. Really, we do really try to improve the VA through research and innovation. And they were able to provide us with a database of veterans who had tested positive for COVID-19. So we were able to reach out to those veterans and ask them if they wanted to participate with us. And so we used the PARTNERme tool, asking about the period prior to the pandemic and current, which was November 2020 to January 2021. And I could probably talk about this project for 5 or 6 hours, but we don't have that much time. So I'm going to try to kind of condense it down and squeeze it. We found a lot of really interesting things, but just to some of the highlights, we weren't sure what was going to happen in terms of, would the veterans lose their social connections? And we did have a minority of the sample indicating that they had no social connections at all. But what we saw primarily was that dependency in their network increased. So there were a lot of increased needs like finances, behavioral health, healthcare needs. And so they depended on the people in their network more. But most veterans didn't have anyone in their social network to coordinate their needs. This was something that we did not know prior to this research, that when these needs arose, when they became more dependent upon their network, the social network was not there to support them, which is quite stunning, and also indicates a need for VA to step in even more than they have and provide support to our veterans. And something else that was very interesting was that we found that low social connectedness was associated with PTSD and depressive symptoms and suicide risk. And so what we see is that this social network analysis does indicate an association with PTSD and depressive symptoms, and then that increases suicide risk. It gets complicated with this type of modeling, but when we take PTSD and depressive symptoms out of the model, there is a direct association between this type of social network analysis and suicide risk. But when we put PTSD and depressive symptoms back in, then it becomes a mediational analysis. But it was very interesting for us to see this, and there are a lot of avenues for us to go down, which I think we'll be talking about in a little bit. So I'll turn it back to Danielle there.
Well, awesome. Thank you all three so much. You can only imagine how lucky we feel at VNL to have the opportunity to get to work with these kinds of folks across these different problems spaces, and to be trusted with innovation and technology in the workflow there's just like nothing short of that for feeling like you're doing something in the world. But it doesn't mean it always goes well. It doesn't mean that it's easy to start. About a year ago, VNL won the Prime Health Innovation Challenge, which opened the door for us to work in pilots in different settings like this. And so while like 14 organizations raised their hands to say we'd like to pilot this, we tried to really narrow on just a couple so that we could really learn from the process, iterate on what we were learning, and see how we can improve the tool. And as you can see, there's interest not only in bringing technology into a solution space or into a clinical setting or what it is, but also just the real learning from it. How are we actually learning more about social connectedness and how it connects to outcomes? So we split this up into 3 sections in terms of, how that kind of worked in working with these pilots or on these projects. So the first section is on just getting started. So if you just are thinking, this is the kind of thing I'm interested in, how would we do that? And I have to apologize. We've just messed this up. It's actually the Westminster Medical Clinic that Caitlin is a part of, not the family clinic. And what we're going to talk though with Caitlin about is really customizing the screener and just making the decisions around what you're going to ask people and why. So we do have just a couple of data points from each of the projects, and then a few more data points from Caitlin on this work. But This is really a primary care example, and you can see there's a lot of different examples. And this is really unusual. We thought for a primary care facility to be screening on loneliness, but integrating it into their workflow. And so far, this has been done in person, but we're already talking about different ways to reach people in different ways that aren't necessarily in person. And this is just an example here of the kind of report that comes from one of the screeners done at the Westminster Medical Clinic, which Brianne and Nicholas might say, that doesn't look exactly like ours, because there's additional measures that we've used in some of these other screeners around some of the different things, measures that were really of interest to Caitlin, in this case, like loneliness, for example. So we're able to incorporate some of those and just learn things like at the really high level, like what kinds of needs people are experiencing. And in the Westminster Medical Clinic setting with these providers, social connection with others is showing up, just followed by work, money, and mental health as areas where people are struggling. And you'll see lower down things like housing or having food. And we see this really flip in different populations, but it's really a nice way to be able to connect these needs to people's outcomes otherwise. Caitlin, you had a couple of more slides about the project. And so maybe just to get started, you can talk through these and our particular project, and then I'll have a follow-up question about getting started.
Yeah, thanks, Danielle. It looks like our identify here, the why is just peeking out there. So I just wanted to build a little bit of context in that last slide that we ended off on of how Art2 goes about deciding what projects they're focusing on as we identify issues. And back in 2018, a couple of the projects with Dr. Rebecca Mullen over at the University of Colorado Department of Family Medicine had done a CARD study, which is also known as a patient survey. We surveyed patients and found across a variety of locations that about 20% of our patients were screening positive for loneliness. Since then, in 2019, pre-COVID and post-COVID, 2021, this past summer, these 8 practices decided that we wanted to really narrow down into what type of loneliness someone was experiencing and categorizing those types of loneliness, because that would then lead us into what types of interventions, what resources, what is the role of primary care and family medicine in supporting social connectedness for these patients. And all of our providers do believe that social health, mental health is really impactful and know and acknowledge more so potentially even than physical health. So I just wanted to point out a little asterisk on this 42%. So we were surprised that back in 2018, using the UCLA 3 item, 20% of patients were presenting lonely. When we switched over to using the categorical loneliness screener, which is called De Jong-Geierveld, then our patients were screening 37% as positive, walking through our doors, and then 42% post-COVID, which is significant to us, knowing that's even more than potentially depression. Next slide. So our wicked problem that we identified was our patients are experiencing loneliness, but we don't have the practice level interventions, the community-based partnerships and interventions, any resources or tools to address loneliness. And we know we don't want to screen unless we have something to do next. So that wicked problem, next slide, Danielle, was something that we then took into PARTNERme, and we were introduced to Danielle. Gosh, I don't know if it was even during the stay-at-home orders or just after, some kind of framing around that. And it was just such a refreshing conversation when we get to meet other people who are thinking the same things, talking the same language. And so we finally had this moment and opportunity to consider what could we invent. We'd been looking in the evidence-based research and identified that we know loneliness and comorbidities of depression, anxiety, also trying to think through the clinicians of Art2 were thinking about things like trauma and primary care PTSD screeners. They also wanted to really sift out what types of social needs were also overlapping with loneliness, because loneliness, it feels like as you keep getting more and more clear on certain things, it becomes more and more complex. Categorically speaking, someone screening positive for emotional loneliness, we would refer to behavioral mental health. If they're screening for social loneliness, then there must be something else there that we can be talking about in terms of maybe quantity of social relationships or learning social skills, and they overlap sometimes too. So we were trying to learn more about what are these characteristics of patients, and then what do our patients actually think would actually help them. And so each of these bullets here has some form or fashion in some studies, but unfortunately, there really hasn't been a lot other than CBT or cognitive behavior therapy to support improved loneliness. So that is why we partnered up with VNL to create a customized version of PARTNERme to help us learn like where people are living and working and playing, and what they actually think would help them, while also gathering this other clinical data. I think that was that my last slide there?
Yeah. And that was great. And, you know, one of my favorite, if you know me, you know, I'm a storyteller, but just the opportunity when we got kind of a ping from Caitlin and we had those first conversations, I think we both have pretty positive memories of that time, because it was right in the midst of COVID. To sort of make these new connections around people thinking about it was pretty meaningful. So Caitlin, I have a question for you, and then I'm actually going to ask Nick and Brianne to also weigh in. But when, you know, we started working on this with you, you brought so much, you and Dr. Hammond and the group, background and research already and ideas around what to measure. And then we said, well, we've got some ideas of how to measure this. And I just wondered if you could kind of talk a little bit about how we actually, and what decisions you had to make, and challenges that we encountered in putting together the right set of questions. How do you know how many to ask? How, you know, do we make choices of, you know, just the pros and cons of asking certain kinds of questions or not asking some, and especially considering the burden, the time it takes, and the limited amount of time we have with patients in clinical settings.
Gosh, there's so much there that we could talk on. You know, I think number one, just finding someone like VNL and like you to partner with from a technological perspective was something that we've always wanted and thought that that was something that could augment what we're doing, but actually finding you was just sort of serendipitous. So I guess number one, the decision to pursue something together was easy for us in terms of what is created and how it's implemented in the practice. With that said, we have a patient advisory council, and they're also a part of learning what loneliness is and how to support patients while at the practice and outside the practice. And so they were involved in also learning what types of questions to be asking. And we were so grateful to VNL that you all were willing to take a leap of faith with us. The questions really came from the literature and what types of care we're delivering already at the clinic. The length of the customized assessment, I think, was something that was up for discussion. With that said, having a captured moment with someone, it seems like our patients are not turned off by the length of something that they're doing from home, whereas everyone's tired of paperwork coming into the clinic. There's fatigue about this paper, that paper. But with that said, I think from home, when our providers help talk it through with patients and say, this is something that I'd really like you to take. Are you willing and able to do this? Whether it's online from home, or we're now talking about doing it from an interview type engagement with a patient prior to seeing the provider, patients seem receptive. And the ones who are ready and willing in terms of desire to make a change and acknowledge there's something here from a loneliness perspective, those are the ones that we're talking to right now. And so all of our patients aren't doing the VNL assessment, but all patients are getting loneliness screening for us to then start talking with them more. So we imagine more and more patients will be taking the larger assessment tool itself too.
Awesome. Thanks so much. So Nick and Brianne, we've gone through the same process with you all. Is anything to add, or tips or thoughts about what people might think about when they're trying to put screeners like this together?
I know for the team at Jefferson Center, so the trauma systems therapy team, one of the questions that we came up with was around triaging mental health needs with the intention of potentially distributing the PARTNERme assessment prior to meeting. And then VNL was awesome in creating a flag that would email our distribution group if one of the questions came back as a positive. And that question was, are there mental health needs that need to be addressed today? And that was our kind of triage. So I really like that was possible because it really expanded the options that we had on how we were going to be using it.
Awesome. Brianne, this was a long process with your team. Maybe you can talk a bit about it.
Yeah, so I think that we had a lot of challenges in the VA. There are a lot of challenges with data collection in the VA. And so, which has nothing to do with VNL. And so, we kind of had to work through a lot of those issues. And VNL really helped us a lot through that. And I think that, one of the nice things about PARTNERme is that it's very customizable. And so we were able, so we could have done this in a number of different ways, because we had PARTNERme, but it was also embedded within a bunch of other, questionnaires that we wanted to know about, related to COVID or related to PTSD and suicide risk. And all those are standardized questionnaires that we can't really change, right? And so we had to figure out a way, how are we going to do these standardized questionnaires and how are we going to do PARTNERme? And so one way we could have done it was we could have just kept all the VNL stuff with VNL, and then we in the VA could have deployed a survey through the VA and done these other questionnaires. So we could have done it like that, but that would have been really challenging for the participant to receive multiple links and really, really hard. And so we were able to come up with a way to take PARTNERme and expand it to include those other questionnaires. And VNL is amazing at working with you on this and helping you through that. And we were able to use the platform very easily, and the support was really great. And so we were able to kind of make it a much easier experience for the veterans to take the survey because of the flexibility of the platform, as well as the VNL team, supporting us in making that kind of survey. And we've done this for another project as well, and it was quite similar, having that input from VNL on, what are the best ways to ask a lot of these social network type questions, and how can we take the other questions that you need to answer that are different from that, and then build it all together in one survey package. So yeah, great experience working with them on that.
Yeah, we get to work with the VA at measuring systems networks and individual networks, but I don't know that if any of you realize how lucky we are for getting to work with you all, because that's the only way that we learn. So you all are being very kind, but it's really, it's our privilege, because it just for having a group trust you really in that way when they're really, spending time with people every day in this way is a pretty remarkable relationship to have. So okay, we're gonna go right forward into our second section on implementation, and Nick is our topic leader on this, really thinking about getting this into the workflow. And we know right now, Nick's team is working on this, and we've had some starts and stops, learning experiences. We've been getting a lot of feedback on them on what we could improve on the tool to bring more value to the tool. And so, Nick, what considerations did your team have to make to really think through how to successfully implement a screener like this and, bring it into the workflow? What kinds of give and take have you had to think through?
Yeah, that's a big question. So one thing about agency work is there consistently seems to be more paperwork and never less. And so our first consideration was, is it going to be worth our time to invest and try to make it work? Is it going to give us a return on investment, essentially? So that was our very first question. And how we came to that answer, which was clearly yes, because here we are, is the workloads of the clinicians. Like I said at the beginning, the trauma systems therapy clinicians often have to serve as case managers in addition to, clinicians. And so we were particularly drawn to this idea that we could map resources and identify those needs early in treatment rather than later. And so we're like, okay, let's give it a shot. On top of that, we did go through kind of this iterative process like Danielle was talking about, where we would administer the tool, come back with feedback, make some changes and alterations, which has been really great. Even prior to this, we were in a meeting, maybe 20 minutes before. So we've been constantly revising what that looks like and how it works. Some considerations we had really were around the prioritization of it, like as far as clinical staff goes, where do we put this in our terms of need? And what we found is that the earlier we do it, the better off we are, rather than delaying it until later in the process, because we want to know where those needs lie. And sometimes the intake questions that are asked, at the time of the mental health screenings and things aren't really sufficient to identify those. So we also have looked at issues with, client follow through, because our clients are very high need. How do we go about implementing this as clinical staff so that we can improve the follow through of our clients following the recommendations for services and even completing the screener? So we talked about the best ways to do that. With COVID and everything, we were looking at kind of a hybrid. We would need a way to administer this assessment both virtually as well as face-to-face. And so we were trying to figure out, well, how do we make that meaningful for people? And that's really what drove the addition of that alert that I spoke about just a few minutes ago. If we did administer an assessment virtually and we had no way to follow up with that, we wanted a way to alert staff that something was pressing and immediate, and we could act on that. So that was one of our implementation things. So we looked at administering through tablets that clients could take and use, or
financing technology services.
We could do
Our conference room.
computers or email, those kind of things. So it worked out rather well.
Awesome. I'm remembering a lot of things, and even as you are presenting, I'm learning to really build something in a human, centered way. It takes this kind of learning step by step. One thing I didn't do, I forgot, was we just had a slide for you on some information about our pilot with you and some of the high level results I think that we're seeing. So on the left there, you're seeing we just did like an interim moment where we gave the team back some data because we want to encourage them to keep doing it, because we want to show them that you're going to get data like this. And we were able to start really seeing a breakdown of what people are saying are their needs and then their most pressing needs. But on the right side, above the maps, you'll see this breakdown of what we are trying to figure out at VNL in terms of how to measure someone at risk or less at risk of low adverse social connectedness versus high adverse social connectedness. And you'll see that in that 12% category over on the right, folks who have low trust but high dependency on folks is something that we're trying to kind of sort out. But then being able to look at like people with these kinds of relationships and their needs is starting to help us learn about social needs and how to address them, and what level of resources people might need. So I'm actually going to go to our third topic just for the sake of time, and then I'll ask all three of you to comment on that one. So our third topic is on taking action. So what do you do when you have data? So one thing I'll point out is Brand's project did not connect to resources. As you've heard, there was a big angle on this around research, but I'm going to ask you to talk a little bit about that. We've pulled some of your results from your project out from a presentation that one of our team members, Dr. Rose Hardy, gave at the American Public Health Association around what we were learning from this project. And you'll hear more about this from Brianne, and then I'll ask one more last question about how to use the data, and then Caitlin and Nick, also the same question about, what does it mean to have this kind of data, and how can it improve the way that we serve people? So Brianne, you have a few more slides, and I'll let you walk through these.
Yeah, absolutely. So on average, veterans had 3 people in their social network. And so we didn't really have a sense of how many people veterans would have in their social network prior to, doing this work. And the average, or the range was, I believe, 0 to 22. So there were, quite a range in there, but the average was 3. And then the majority did not have anyone to help them with their needs, which was very surprising. So, as I mentioned before, so, they have a small network to begin with, and then those network members are not reliable in terms of being able to help them when they experience needs. And we did see this rise from the pandemic in needs. And we know that a lot of those needs are associated with suicide risk. So we are getting a much more nuanced picture of what's going on with veterans from this analysis. So now we can see more of the fact that, veterans have these needs. They're not able to rely on their social network, and that's increasing their risk of suicide. So what we see here, we're also interested in something that's called social cognition. So those are the skills that underlie social interaction. And that has been studied probably the most in autism and schizophrenia, but I'm also interested in that in relation to post-traumatic stress disorder as well. And so we also had that in our model too. And so what we see here is that, we have this, we have our social network analysis. Higher scores indicate worse social connectedness, and higher scores on PTSD and depressive symptoms indicate higher PTSD and depressive symptoms. Higher scores on suicidal ideation indicate higher suicidal ideation. Higher scores on social cognition indicate worse social cognition. And the measure we use is a measure of social cognitive bias. And so if you're in an ambiguous situation, how do you interpret that situation? Do you blame somebody else, or do you blame it on the situation? And so what we see here is that, the worse social connectedness somebody has, the higher PTSD and depressive symptoms someone has, and then the higher the suicide risk as well. And social cognition contributes to all of this. So the worse social cognition, the worse social network they have. The worse social cognition, the more PTSD and depressive symptoms they have. There are also indirect associations between the social network and suicidal ideation through PTSD and depressive symptoms, as well as social cognition to suicidal ideation through the social network and PTSD and depressive symptoms. So we get a lot more of a clearer picture in terms of, where are we going to intervene here? Well, we have a lot better understanding of what's happening with our veterans. So the quality of social relationships worsened during the pandemic. The poor quality of relationships was associated with increases in mental health symptoms and subsequent suicide risk, and low social cognition contributed to those poor relationships. And many veterans didn't have anyone in their social network that they could rely on for their needs. So if we're thinking about, what are we going to do next here? I think that that we really need to be working on, what is the VA's role here? Because the VA has a role in providing veterans with a lot of resources. But I don't think that the VA understands the extent to which veterans don't have strong social support networks surrounding them to address their needs. And so, if you think about things like food insecurity, the VA doesn't typically help with something like that, but that can really contribute to, poor outcomes in a veteran. And so I think that we need to be providing more things like intensive case management. So the VA started doing that internally, but we need to also be providing external resources through intensive case management, really understanding the veterans' individual situation in terms of their social determinants of health, and helping them, with additional resources, and trying to help them build their social networks in order to reduce mental health symptoms, improve suicide risk, and improve functional outcomes as well. And so, next steps of this work is that we're in ongoing data analysis for publication on this. And there are a lot of different findings as well. Again, could talk about this for a long time, but we're short on time. So just really a huge thank you to VNL. We would have never been able to do this without the expertise of VNL. And this is really a kind of a dream come true project for me. I've been wanting to do this for a long time, but just didn't have the expertise or know-how myself. And being able to partner with VNL was really wonderful. They're an excellent company, and just really appreciate all of their help and support on this project, and looking forward to getting all this published out in the world and our continued collaboration.
Yeah, well, this is really great, and we're actually getting to expand into a couple areas around looking at veteran social connectedness. So it's been a great partnership. If anyone has any questions, if you want to put them in the chat or even raise your hand, go ahead. And I'll ask Caitlin and Nick one last question if we don't have any in there. And then for anyone who wants to stay on, we're just going to do a very informal discussion and more Q&A about like, how would I actually use this, and what does it look like? So very informal if anyone wants to stay on. But since I'm not seeing any other questions, for Caitlin and Nick, just to end, I think the big question is the so what, right? Like, so Brianne just gave a great so what for why it matters to her. And I just wondered if you wanted to close with anything around, what are you thinking this is going to do in terms of impact, in terms of how you can help people that you serve? Maybe Nick, there you go.
I'd be happy to jump in there. One thing that we really strive for is to help our clients feel confident and comfortable and self-sufficient. And we know that building reliance on a therapist or a provider isn't a long-term solution, that we need to expand those social networks, and we need to find those resources that are more consistent. And so our hope is that through the use of the PARTNERme assessment and subsequent referrals and follow-up, that we can build those networks for families so that they are more comfortable and confident going forward, even after the therapeutic engagement ends.
Awesome. And Caitlin.
Yeah, I was just looking at one of the questions in the chat. Do you want me to go there?
Sure, that'd be great. If you have time, I know we're just at time, but if you have a minute.
Sean mentioned you have used examples of surveys to patients. Have you surveyed other providers in the network for their connectedness to the patient? And so I'm assuming that's to the ART2 network, but if that's another path, let me know. So yes, we have actually surveyed, coming from a place of supporting people if we are strong at our core too. So we have surveyed internally both our connectedness as teams in our practices, which it turns out it is higher. And then we've also surveyed in a separate project, unrelated, but that brings up an interesting point, to look at how patients and providers are perceiving their social connections and their relationships and how they're speaking about them, and are they all on the same page? And there's some metrics that we've used for that that has definitely revealed some next steps that we've taken. So that's a great question, but yes, all of that has turned out to be really helpful.
Excellent.
Yeah.
Caitlin, so this is a a good moment if anyone needs to drop off, and I don't know if our speakers do, but there are a couple other questions. So if you can stay, I'll read them out. We did plan for extra time, but it says for Nick, how do you assess client confidence and comfort in going forward?
So yeah, I was actually typing the response. I'll just say it then. Okay. So it depends on when we talk about confidence and comfort and moving forward, whether we're talking about the therapeutic engagement or the use of the tool, because I think both are very relevant. So in terms of use of the tool, we are primarily administering these face-to-face, if at all possible. And the reason we're doing that is so that we can have that personal connection with a client. In the virtual one, the emails and things, oftentimes we've had Zoom sessions and things with clients. So they're a little more comfortable in sharing that information, because I know Kelly asked that question that's pertaining to that as well. So our goal is to first and foremost identify the need and then work with families throughout the therapeutic relationship to build those networks. And so we're consistently checking in with them on, did you follow up with this referral? And VNL actually created a follow-up or a subsequent evaluation that we can do with families, which is really cool. So we follow through and just ask, how's this going? What barriers did you have? How can we overcome those barriers? Sometimes it's as simple as clients not knowing what questions to ask or not knowing what they're asking for with certain organizations. And so to help them answer some of those questions before they make the phone calls and before they send the emails is one of the ways we can build their confidence and follow through. In terms of the therapeutic engagement, it's really around those core tenets of like safety and regulation, and then beyond trauma, where when we leave a system, they're essentially going to be on their own and they're lacking the case management that we have provided for the past year or so. And so we want to enable those families to still maintain relationships with those providers that we've connected them with, is really where we're kind of focusing there.
Excellent. Great. And I'm just going to add one thing, because I learned this from the providers at the Westminster Medical Clinic when we had a different conference session. And I remember one saying it's difficult to start the conversation around something like loneliness. So she said, you just do it. I was like, oh, okay. She said, you just finally do it. You just start. Let's see. I don't know. I think we'll answer any more questions, in the chat, unless anyone has any. I want to be able to make sure we switch over to and let our speakers go if they didn't plan to stay for this next part. And there is a question about the future, where you see the future of this data and technology. Maybe we'll just end with just a word or two on that. Where do you see the future for this kind of data and technology in these kinds of settings? Maybe one quick word from each of you, and then we'll say goodbye.
Yeah, I think for at least our providers, they're looking to continue having in-person relationships with patients, and this level of information comprehensiveness is something that they've always wanted. But I think the technology there and getting more specific on how to be strategic in their support of people and exploring and testing that, just like you guys were also talking about. And is this helping them diagnose loneliness? If loneliness is a diagnosis or not. So that's something that I think in the future, technology has to be there, but it's just how we're going to use the data.
Yeah, great. And Brianne and Nick? Yeah.
I think for us, especially since I've talked a lot about the resources, it's connecting to the people to the right resources the first time. Rather than sending people on a hunt for those, we want to identify those needs and connect them to the people that we know can help, just to minimize the burden.
Awesome. Last word.
Yeah, I'm a clinical psychologist by training. And so I was trained that, your client needs to go find their resources on their own and you're supposed to work on their mental health symptoms. But I think that we kind of see how well that has worked. We still have very high rates of suicide, and we really need to be looking at the whole person. And so when you have a tool like PARTNERme, what you can do is you can provide that tool to a person and truly understand their needs in a very quick way, and then help them through different methods. You could just provide them with the resources, or you could do something like intensive case management, and help them connect to resources that address a lot of the needs that, in my case, are drivers of suicide risk. And so I think that it's a really nice tool. And then you can look to see over time, did that person connect with these resources? Are they expanding their social network? Are these things like loneliness being addressed through what we're providing them? And so I'm really excited about using this tool in the future. We're just starting to try to validate it as something that is associated with mental health and suicide risk. And so if we provide an intervention on top of this while using this tool, is that going to improve, mental health, functional outcomes, suicide risk in veterans and in other populations? So I think that there's, and then I could go, last word, I could go on about this for a long time, because there's also other broader, things with networks that we're working on in some of my other projects with VNL. There's a lot of uses for this tool. So it's very exciting.
Well, thanks. And the last thing I'll say is, a huge challenge we're still facing is how to integrate it into things like existing EHRs and medical record. That's just a lot of work. And so bringing new technology is, you can be shiny and you can be even high functioning and well resourced, but getting it into the workflow and making sure that it's actually enhancing, especially our limited staffing issues that we're having right now across many of these fields, is really, I think, some of the things we're going to have to figure out as technology tries to be a solution to big hard problems. I want to say thank you so much to the three of you. You all are we're huge fans of you. You're really important to us, and that you'll spend this extra time with us doing this kind of work is we just priceless. We can't even thank you enough. And we look forward to our continued work with you. So if you want to stay on, please do. You all have seen how it works, so I wouldn't say necessarily that you'll learn something new, but you're welcome to stay. What we're going to switch over to now is just a little demo of the platform for anyone else who's on the call and just wants to see that. So thank you to you three, and we will speak with you soon. And if anyone has questions for them, I'm sure we can connect you to each person. So. Okay, well, thanks. Okay, I'm gonna switch over for anyone who is staying on. And if anyone who's staying on has a particular question or interest in what they want to see, let me know, because I'd be more than happy to customize this in any way that I can. So I think what I'll do right now, though, is just a quick kind of demo of the platform so that you can get a sense of what it actually does and how it works. But please even unmute yourself or turn your camera on, and I'm very conversational. What I'm going to start with is I'm inside of our platform. It is online, and we've done a lot of work to protect people's privacy. In some of our cases, we will collect PHI. In most cases, we don't. So we've created a mechanism for that. And we've basically, I'm skipping a few screens here just to kind of get to the part that I think you might be interested in. So this is part of what a person sees on their tablet or phone or computer when they're answering questions. And then I'm going to show you the back end, which you would have as an administrator. So this is a set of questions, for example, the ones that I mentioned in the demo, kind of the slides earlier, might be questions about their mental feelings around their mental emotional health or rating their overall health. This was preceded by a number of other questions. And then what we can do is add all kinds of, this is the loneliness screener, but then this is a part where people are asked, for example, who are the people, organizations, programs, and others that you rely on when you have problems or need support. And that's the kind of thing that people can customize in any way. So I might here say my mom, oops, I was just in here right before this. So let me do this again. So let me see if I put my dad, there we go. I've lost a node when I went back and forth. And then if I put, let's say my doctor, and then I include my neighbors. So what we've learned is that people put their friends and family, formal supports and informal supports. I'm going to do something I don't usually do live, but I'm going to refresh this page and see if that brings my little nodes back. There they are. I lost the one on mom when I went back and forth. So what's fun about this is that when people enter these things, a little map pops up. And what I always talk about is the way that people really lean in. So when you're being asked questions like this and you're being, you're given the tablet, people tend to just really lean into it. Which is different from us being asked questions where they're answering on a clipboard or putting it in their computer. So after someone does this and it's interactive and colorful, we ask people, for example, here, who works together to coordinate care for you and your child? So that would have been on this particular survey. And with my mouse, I'm making these connections. And this is a real difference that we see for people in terms of whether they have a lot of connections or not. We almost can't predict it. I always say on a call like this, all of us on this call, if we had a crisis this afternoon, I have no idea if you have someone who can help you and whether there are groups of people who can coordinate care for you. It's very invisible. So this gives us some insight into a person's thinking on that. And then we ask, oops, I skipped the question earlier. I don't often do this. I'm going to go all the way back to it because I skipped it to try to save time, but there was a question that asked what their most pressing concerns are. So let's say that they picked childcare, food, and money. So then I'm going to keep skipping some and get back to that screen. And here we go. So it saves everything. So here now it asks who helps you with the things you need. So this is where I can really capture like, well, I've got a couple of folks helping me with some money needs that I have, and my neighbors are helping me with childcare, and maybe food. And if we can actually take these off but nobody's helping me with certain needs, and I can find a most pressing need without any support. And so what we're looking for is this kind of configuration, and some people have a lot of support and some don't. So this helps us understand that. And then we also can ask people what kind of person this is, maybe to what degree they depend on them to help them when they need it, to what degree do they trust them to help them when they need it. And all of these things give us more of a sense of the nuanced relationships within these relationships. And you can include these or not include them. At the end of the survey, there's the possibility for you to turn this off, but you can also allow a user to go right into their own profile. Most of our providers do turn that off. They prefer to actually have someone see their maps and their results first with the provider and then review it on their own after. So what I'm going to do is actually go back to the back end of this. As I mentioned, most people do turn that off. They turn off the ability for someone to see it right away, but sometimes we'll turn it back on after a person has reviewed it with the provider. That means that they're given access to the data, they're given access to the resource list, but they're not necessarily seeing it without that interaction of a professional or someone to walk them through it. So those are all options. It is very customizable. What I'm doing right now is kind of going to the back end of PARTNERme, where you could come in, and this is where you're going to be able to see every node that's inside your system. So by that, I mean, it's respondents, but it's also your resources that are listed in there. And also all of the alters, which we refer to as the people who people nominate as folks who help them with the things they need. But if I go to respondents, I can kind of sort through this and see who's answered the survey or not. Ideally, these would be connected to your ID within your medical record. You can also put the person's name in here, but then you are sharing PHI. But if I pick one of these, what it allows me to do is go to their results. So you get these results the minute they're done with taking their survey. And I picked one right here that does not have a notification, but as Nick mentioned, the user can identify certain needs that trigger a notification. We refer to those as critical needs. It could be something like experiencing violence or having suicide ideation, things that you would want to know immediately. And so if a person is at home or even in clinic and they answer with those things, a notification immediately goes into the designated person email box, but it also appears here at the top as an orange tab to let you know. And so for that, that way we can really capture some of those needs immediately. The blue lines are showing high dependency and the dotted lines are showing low trust. So a dotted blue line shows that even though they're saying dad is part of my network, it's a relationship that they're highly dependent on, but don't trust to help them when they need it. That is actually one of the ways in which we identify adverse social connectedness, is people who are connected to a lot of others, but don't necessarily have trust in those others or are very dependent on them. These quick visuals might look kind of overwhelming at first, but after you do this a few times with a few patients, you can really start to quickly get a sense of what your patient is experiencing and what kind of social connectedness they have. And then we do offer these scores of things like trust and dependency, loneliness, and so forth. The one thing you might be interested in, we didn't really go into much, is the resource list. So resources come from all different places. Our platform's really flexible. We're kind of agnostic to the resources, but if you want, you can we can work with you on connecting it to a 211 or an Aunt Bertha or another system. But most of our users have a binder or their own Excel sheet of resources. So we can bring in any list of resources. We don't automatically update them, but our users will re-upload their lists as they update them. But what this allows us to do is if a person said these are the things that they need, you'll see them as lists right here. But what our users do is they come over here to this resources tab. And right here's where they can really customize this. So we do have GIS data in here. And if you have data in here on your patients' locations, you can map them as well. And you can see if patients are connected or are located close to where the resources are. But this suggested for you box is really critical, because what this allows you to do is customize the resources for the people that you're working with. So by clicking this little pencil right here, it shows me all the resources in my database. But I have different ways, like by city, zip code, or their needs are tagged here. With Jefferson Center, we're working on some revisions to this to allow better filtering and ways to add to this list. But this allows us to, what we've heard in terms of feedback is that people get really overwhelmed by having a big list. So what we're trying to do here is make that list a little more customized and targeted either by the provider's preference or by focusing on their most pressing need with the least amount of social support. But the filters that we're bringing in will allow you to filter by location to those things, or things like eligibility criteria and stuff like that. And that allows you to pick the resources that you want this person to get connected to. And when I hit save, it creates a suggested for you box that's customized for them. You can actually do the same on each box, which we've learned the more you can make this less overwhelming for folks, simplified, the more likely they are to be receptive and follow through. So we're giving a lot of tools for that. And at the top, you can save these as PDFs and put it into their medical record, any of the results, or you can email it to them and email the resource list so that they have the contact information as well. A couple last things is underscores. If you have different scores or the scores that we provide on trust and dependency, you can see it a little more broken down by different people. So there's a little more nuanced information amongst these different areas of this. And you can also take any of these and bring in your own questions, and they will show up on all of this. These profiles are customizable, and there's actually two views. There's a view that the patient can see and the view that the provider can see. So sometimes we don't want the patient to see everything, more because it's overwhelming for them, rather than that we don't want to share their own data with them. But there are different views that you can customize so that you can really manage that relationship and that sharing of data amongst people. I want to pause and just make sure there are no questions or anyone wants me to repeat anything or see anything in particular for a second. And if not, I'll show you one last thing. Okay. That's good. It makes it easy on me, but I also feel like I might not be giving all the information. So that's the member profile. And over here, you're going to see, let me go back to the project. There's a button at the top that says Analyze. So when we click on that Analyze button, there's a few things that we at VNL are still building, we're working on. So the systems map that you see right now doesn't filter quite the way that it's going to when we get it set up correctly. But this is where you'll get to see from a systems perspective, the people at a high level, what their needs are and where they're getting referred to. So we take the provider's selections on suggested for you, and then we put that into this map so that you can track from a population level where people are getting referred, what needs they have, and you can see it visually. We do provide a GIS component to this that allows us to go kind of in depth into the location of resources and people. And we have some county health ranking data in here, but you can bring in different things that can help you do maybe some exploratory look at your data, especially from a population level. So at the systems level, this is the kind of stuff that's really helpful. There's just ways to kind of provide scores around different resources or people and things like that. And that's what happens on this screen. And then the charts and graphs screen allows us to do things like look at answers from a high level. So this right here was the question, which of the following are your most pressing concerns at this time? And that allows us to see what people said, for example, in this sample, food, followed by emergency needs. So at any point in your tenure of using this, you can come over here, and this is an active, always updating set of information and data. And we're always introducing new features into this. Very shortly, you'll see cross tabs, and then our longitudinal analysis is something else that we're bringing in really soon. But anything that you customize in your screener is going to pop up over here. So we do our screener customization in these features right here, manage our members and including patients and resources here. And then we do our analysis from here, and it's all connected. So you'll be able to see that. And we do provide reports. They're not automated through the platform right now because with our pilots, we're creating individual reports for each of these sites, and then they'll give us feedback on them, and then we'll program them in here. So that's kind of a pretty high level of how the platform works. And you've heard a few things from some folks who are using it. So I just want to make sure if anyone does have any other questions or comments that we can address them. And if not, that's okay. I will suggest that if you're interested in what we're doing and how we're to use this tool, there's a number of ways that we can kind of walk you through that. And you'll see Kelly, who's on this call, is a great contact for that, and the person who helps to guide people, through the process. So. Okay, well, if that's it, there's Kelly in the chat, and no one does have any other questions. I hope one thing that you have seen today is we are very accessible and really excited to continue relationships with people who are interested in measuring this kind of thing. And so I do hope that you will stay connected and let us know if you have any other questions at all. And if you want to reach out to any of us or the folks who presented today, just email Kelly and she will get you connected. So thanks everyone. And I hope you have a great rest of your week.